Let me tell you a little bit about the IETF. We're a 501c3 nonprofit organization, and our mission is to fund research, to find better treatments and the cause and eventually the cure for essential tremor. And we also work to increase awareness about ET. And we provide support through the development of support groups worldwide. And then we provide educational materials, tools, and support for healthcare providers, the public, and those affected by essential tremor. So basically, whatever you can think of, the IETF does it. We also are in DC. We have volunteers in DC that are actually working to educate the legislators there. And it's been really an experience because I didn't realize how many of them thought that if you shook, you had multiple sclerosis. If you shook, you had many other things. And they didn't relate it to essential tremor. Essentialtremor.org is our website, and it contains webinars, webcasts, ET literature. I do want to say and give us very special thanks to the presenters, Drs. George Plotkin and Paul Detwiler of ETMC Neurological Institute. And the reason why I want to do this is they're donating or volunteering their time today. They weren't paid to be here. They just want to help share the information that will help you become more of a partner with your physician in treating your essential tremor.
So I'm going to talk a little bit about tremor, about essential tremor. It is not benign essential tremor. All of you in this room know it's not. There's nothing benign about it. It's not a disease. It is a state. It is as old as dirt. In Genesis, there are 24 or 26 references, depending upon how much Greek you know. Tremor is an old Greek word. It means to shake. And there's been a lot of that from biblical times on. Essential tremor occurs everywhere, affects everyone. It is a dominant trait. I'm just sort of getting all the things off that we talk about again and again, because once you understand those, you have a bit more appreciation of what we're talking about. The bottom line is that we don't know what causes it. Well, we all get tremor if we get cut off by an 18-wheeler on I-20 on an icy morning. That's called enhanced physiologic tremor. It's because the back of the brain, the cerebellum, which is involved in tremor, we think, because anytime you damage it, we get tremor. So it's a clue. The back of the brain has as many cells as the rest of the brain. The cerebellum has just as many cells as the whole rest of the brain because it's one giant timing circuit. The back of your brain is like basically it's like a Toyota truck with a V1 billion engine with 1 billion cylinders, and they're firing in timing. You can say, why do you need all this timing? Well, you got to coordinate movements. So the purpose of this timing circuit is to fire all these muscles randomly. And if you have 1 billion cylinders, you can imagine that you might find some errors. And those errors are firing errors where everything fires at once, and so you get these rhythmic oscillations, which we call tremor. This is what we call dominant Mendelian disorder, which means that if one parent has it, half the kids have it. People say, well, there's no one in my family with tremor. I'd say you just haven't asked. So genetics really are important in this disorder. Somebody said, well, what causes tremor? And I started to make a list and I realized everything causes tremor. So when people have no family history and they're on medicines, cytarabine, so if they're on chemotherapy, all the seizure medicines, especially Depakote, which is used for mood and behavior, all the asthma medicines, all the immunosuppressants, all the mood stabilizers, and all the stimulants. While we're at it, all the antidepressants of every flavor, all the heart medicines, most of the antibiotics, most of the antivirals, alcohol suppresses for about 2 hours and you get rebound tremor. Nicotine causes shaking. Blood pressure medicines can, and obviously adrenaline, and drugs to try to lose weight, thyroid medicines, and then even a drug to try to treat movement disorders causes tremor. So we'll see kids who've been on tetrabenazine, they develop a new tremor. I have people come in the office, their hands are dead steady, holding out in front of them, but they try to write and it's all over the page. And so we have to keep in mind, you have to think about what makes your tremor worse, because it may be how you can make your tremor better. The disability with essential tremor is that you change your lifestyle. Basically, 60% of people who are diagnosed with essential tremor do not seek advancement in their careers, or they change them. But if you have essential tremor, you feel people think less of you. I have a salesman who comes in for evaluation and basically says it's hard to make a sale when people keep staring at your hands. You know, they're just so preoccupied with, oh my gosh, he's shaking. So we have some medicines. Gabapentin doesn't work very well, you probably know. Lyrica might work a little bit, which is another pregabalin. Topiramate works very well in select population. Primidone works fairly well. Combination therapy of primidone and propranolol in the appropriate patient is about 30 to 40% more beneficial than either drug alone, but it has to be titrated carefully. These are drugs that you can't just slam on people. Primidone causes nausea, and so we try to walk up very slowly. Benzodiazepines may work a little bit, but the trouble is you get accommodated to them, so-called tachyphylaxis. The drug stops working, and you get just side effects. And finally, what I'm going to let Dr. Detwiler speak about is what we've found to actually work for this disease after years of exploring surgical options, because it's occurring in an area of the brain that has been well identified and the neurosurgeons have a lot of experience with for other reasons. And as a consequence, deep brain stimulation has become one of the mainstays of trying to treat tremor in patients where the tremor is refractory and disables them. And that's the key, it's disabling. If you can't do what you need to do, then the tremor needs to be addressed in different ways, and it's a part of the spectrum of therapy. It is not a last resort, it is not a last gasp effort, it is part of the mainstay therapy.
So why consider surgery? Well, it's a disabling disease. There's a wide spectrum of presentation. Typical complaints: I can't thread a needle, I can't sign a check anymore, I can't play golf anymore, a whole bunch of different things. Then there's the medication side effects that are intolerable to a lot of patients and pushes them over the edge. And we see that with the Parkinson's disease too, where a lot of times patients will come to me and they'll say, wow, if you get rid of my tremors, that's great, but what I really want is I want to get off or reduce the dose of medication that I'm on. And then in some people, it could potentially jeopardize their quality of life. In going through these slides this morning when I got up, I thought to myself, I wonder if there's a neurosurgeon out there that actually has a DBS unit in him. It's, because I couldn't do my job if I had essential tremor. For essential tremor, we really don't do brain mapping. We don't do intraoperative electrode monitoring. We've gotten so good at hitting the target that we basically position the patient on the table, we put the stereotactic coordinates, put the electrode in, we stimulate. If we shut the tremor down, we're done, we close. The actual battery and connecting cable get placed at a later date. So you come back after the electrodes are placed for elective placement of the generator and the connecting cable. The reason we don't put everything in and turn it on the same day is because as the anesthesia gases are wearing off, we could turn you on and program you to what we think is a good response, and then you go home and it turns on us and we're driving your tremors. The first program is 2 to 4 weeks later, and this is something that happens in conjunction with the neurologist and the nurses that are working with the neurologist. So the surgeon really sees you in consultation, you have the electrodes put in, you see them 2 weeks later, they put the generator in, and then the neurosurgeon kind of fades away. And then you don't see the neurosurgeon again unless you need a generator change 3 to 5 years later, which is an outpatient procedure that takes 12 to 14 minutes to do. And you go home the same day. I mean, it's amazing to put this electrode in and turn it on, and all of a sudden the tremor just stops immediately. People think that it's just, really something special to watch. And it's a life-changing. With DBS, it's adjustable, it's reversible. Downside is there are surgical risks. A risk is really a complication. There are complications that we can fix, and there are complications we can't fix. So when I talk to patients, I talk about both. Basically, it's beyond well accepted throughout the world that DBS for essential tremor, not well managed medically, is something that is beneficial. The insurance companies are on board, Medicare is on board. If I were gearing up to have this procedure done, I would want someone who's done a lot of these, who has a very small complication rate when it comes to infection. That's really the big thing. both the neurologist and the neurosurgeon's experience becomes critical. When we look at the center we've built here, we have 3 surgeons that all trained at top residency programs that are very busy. That's very odd. You won't find that around the country. Are there any questions?
We have lots of people come to us who have been to excellent neurologists, and there are a lot of them around here. Really stellar, competent doctors. And they have tried every drug. There's a handful of them. As you probably saw, it was less than a page. If those aren't working, we're going to give you options that are not drugs. Some of them are simple things, like putting a strap on your wrist, wearing a pen that has capacity to make your writing better. Put weights on your hand, put weights on your pen, put weights on your spoons. There are lots of things. It depends what the disability is. We don't eliminate anything from the table before we've actually seen you and talk with you. So that every patient's unique. I have patients where they'll come and they say, do you think I should get DBS? And it's like, heck no. Others come in and it's like, I've been on every drug known to man, the tremor's miserable, I can't do anything. And my question is, why haven't you thought about DBS? Oh, that's surgical, it's terrible. No, it's not, it's an option, and it's a good one. And we've had people come back afterwards and say, I wish I had done that earlier. I don't think I've ever met an ET patient who said, boy, I wish I never had done that. That just doesn't happen. The satisfaction rate's well over 90%.
Does anybody else have any questions?
If not, we'll close it for now. What I would like you to do, though, is to help us increase awareness about ET. That's really, really important. So thank you all for coming. We greatly appreciate it.